Good evening, doctors. This is Harish Murthy from Microlabs. I welcome all of you heartily to this first of our webinar series called as Beating Hearts. The topic for today, as you know, is role of bisoprolol in young hypertensives. Dr. Muruganathan is in conversation with Dr. Sarat Chandra, who will be the speaker. Dr. Muruganathan, all of you know, uh, is a well-known figure in the field of medicine and cardiology. He has been a past emeritus professor from the Tamil Nadu MGR University. He is the international advisor for Royal College of Physicians, Glasgow, international member of the Medical Education Board of RCT Glasgow, advisory council member of National Board of Examination. He is also the director of Hold Medical Academy and chief editor of MediBeats. And Dr. Muruganathan, has been the immediate past governor of the American College of Physicians India chapter. And Dr. Muruganathan has been the Dean, Indian College of Physicians from 2016 to 17. He's been the president of the Hypertension Society of India from 2015 to 16 and the president of Association of Physicians of India from 2013 to 14. It's a honor, sir, to have you here. And I would, on behalf of Microlabs, welcome both Dr. Muruganathan and Dr. Sharat Chandra. And I now hand over the session to Dr. Muruganathan.
Thank you very much. Good evening, my dear brothers and sisters. Following the World Hypertension Day, which happened on 17th of May, now a lot of activities are going on hypertension. One of the important aspects of hypertension, especially in India, we get a lot of young hypertensives now. I think if you see, more than 14% of the people who are having hypertension are less than 40 years. So it's really alarming, especially when these people are in the software industry. They don't have system, they don't have any lifestyle modification. They all get a lot of problems, especially hypertension. And again, different people define young in different way. Some people say less than 55 or more than 65 is old, less than 55 is young. But whatever it is, even less than 40 years, the statistics says 14% of the people are having hypertension. It's quite alarming. Okay, now today our learned speaker, a great academician, a great professor, a great communicator, a great cardiologist, now he is going to talk to us on the young hypertensives and the role of bisoprolol, a beta blocker. What is the role? Many international guidelines, they don't give importance to beta blocker as a first line drug. Whereas in India, we give much importance to beta blocker, especially in younger people who are anxious and especially women who are going to be pregnant. This beta blocker is very useful. I think Sarat Chandra also was the one of the authors for the India heart study, where they found in India, the average heart rate is 83. So definitely we have to use beta blocker. And that too in an young hypertensive, beta blockers are very, very useful. And today's talk, our Professor Sarat Chandra, a consultant cardiologist, he did MD in PGI Chandigarh, DM also in PGI Chandigarh. He's a junior cardiologist, Railway Hospital in Perambur. And then he was assistant cardiologist, Durgabai Dismukh Hospital, Hyderabad. Now consultant cardiologist, Apollo Hospital, Hyderabad, Medwin Hospital, Hyderabad, faculty at NIMS, consultant cardiologist, Indo-US Super Specialty Hospital, and Vinci Hospital, Hyderabad from 2012 till date. He has done a lot of work on various aspects of cardiology. He was the editor. He was academically very active and a good communicator. So his work on hypertension is exemplary. So he is the right person to talk about young hypertension and the role of bisoprolol. Of course, now the newer beta blockers, The beta blockers have started coming to the market in 1960 onwards. And now the third generation or the recent beta blockers are which are good, like bisoprolol, metoprolol, nebivolol. We use left and right for all patients, even though they may not have any cardiac problem also. And our beloved speaker, Dr. Sarachandra, is going to highlight what is the role of bisoprolol in hypertensives. My dear brothers and sisters, please post your question in the chat box, and then Dr. Sarachandra and myself will try to answer and clear your doubts, because this is a very important topic, especially young hypertensives. We'll have to focus and concentrate this time, because the awareness among the young hypertensives is less. Slow detection, slow treatment, not taking treatment are the main reasons why the young hypertensives are not controlled. They don't submit themselves for a BP checkup. That is why we always say opportunity screening. Even they bring their parents for checkup, we'll check the attender who is young also for blood pressure. There we can, thereby we can diagnose early detection, and then continuing treatment is the key. And then creating awareness and education to the young people are very much important. So with these few words of introduction, I have great pleasure in welcoming my friend Dr. Sarachandra to deliver his lecture on role of bisoprolol in young hypertension. Over to you, my friend Sarachandra. Thank you.
Thank you very much, sir. So, when Dr. Muruganathan is sitting there and says somebody else is having exemplary work on hypertension, that is an exaggeration. Dr. Muruganathan, as you all know, he has done everything in relation to hypertension. I mean, vast number of publications and lectures and so on. We all have learned so much from him. Just to add to my CV, I was the editor of Indian Heart Journal in 2012 to 14, and I was president of Cardiological Society of India in 2018. All right, let me have the slides, please. Okay, can you maximize the size? Can you make the slide bigger?
Sir, you can increase the size by clicking right bottom. There is a one square. Just click on that.
At the bottom of the
that screen, that's corner of the slide, sir. There is a one square. Once you click on that, it will maximize. Yeah.
All right. Thank you. Okay, and now to go forwards, backwards. Okay, I can see it here. All right. So, as Dr. Muruganathan just now said, we just had the, hypertension day of the world just on the 17th of this month. And, I will just describe to you the details of one particular patient I saw on that very day. He's 47. He came to me having been referred by an ophthalmologist, and he went to the ophthalmologist because he had a reduced vision in his right eye. And the doctor has diligently examined the patient and wrote that there are signs of hypertensive retinopathy with macular edema, which is probably responsible for his reduction of vision. And she said, you go and get your blood pressure checked. That's how circuitously he came to check his blood pressure. He never checked his blood pressure at the age of 47, and such is the poor knowledge even today. Even today, when we talk so much about preventive cardiology, prevention of hypertension, diabetes, and so on, we still see patients like him. And then his blood pressure was 220 by 150. And then she wrote that this is malignant hypertension, go to a cardiologist. He came to me, the blood pressure was still very high. And his evaluation showed that he already had elevated serum creatinine. His calculated EGFR is around 60. And the patient otherwise had no cardiac symptoms, no symptoms whatsoever. But he already suffered damage in his eyes as well as in his kidneys. His left ventricular hypertrophy is also present on echocardiogram. Electrocardiogram was surprisingly normal. Well, not very surprisingly, because we know that left ventricular hypertrophy is the gold standard is echocardiography. The electrocardiogram may or may not have changes, but we know that if left ventricular hypertrophy is also evident on ECG, his prognosis is far worse. So on one area, he is relatively saved in one area, but he already has such disastrous disease. So anyway, so now we talk of role of bisoprolol in young hypertensives. As already mentioned, the exact definition of this is not clear. It could be 40, it could be even young adults. Many of the lot of data which will be presented to you today pertains to those patients who are less than 40. All right, the next slide. Okay, hypertension is the leading risk factor for comorbidities and death globally. The World Health Organization has estimated that more than 1.5 billion will have hypertension by 2025. This was the prediction in 2012. Probably it will be exceeding that figure. And you can see among all the comorbidities, people are predicted to have 58% are predicted to have high blood pressure, cholesterol, which is elevated in 45%, ischemic heart disease in 31%, arthritis 29%, diabetes in 28%, all figures which are very, very scary. Heart failure is mentioned as 16%. Imagine the numbers. Okay. This is a slide that shows that 1 in 5 young adults in India has high blood pressure. This is published by Ramakrishnan, who is a very popular doctor from All India Institute. Incidentally, he's from Tamil Nadu, but he is in All India Institute for a very long time. This is a very good study published in Indian Heart Journal, incidentally, in 2019. The prevalence among women in that particular study was 23.7% compared to the much higher prevalence among male participants, which was 34.2%. Now, these are the figures in the overall group, as you see on the right-hand side of the bar diagrams. But if you go to younger age groups, you can see the difference. When you look at 18 to 19 age group, the difference between females and males is far greater. The difference becomes correspondingly less so, and at the age of 65 to 75, there is hardly any difference between the sexes. So the number of people who have the young adults who have hypertension, it comes to 80 million people, more than the entire population of United Kingdom. That is, of course, the strength of our country. All right. So it just shows that in this particular study, men are more commonly found to have hypertension at younger age, but as time passes, the two sexes become equal in their numbers. Risk factors for hypertension in young adults. It is, of course, sedentary lifestyle. As mentioned earlier, the software company people, you see so many of them coming with hypertension because of their poor lifestyle. They're awake in the night when everybody is sleeping, and they sleep in the daytime, completely altered cycle and diurnal cycle. And of course, because of their long sitting, they tend to develop overweight and hypertension and diabetes, which we see routinely in Hyderabad, which has a huge population of software industry workers. I'm sure it is the same in Chennai or Pune or any place where the software industry has mushroomed. And of course, diabetes is a risk factor. As you all know, 80% of diabetics will eventually develop hypertension. And hypertensives, nearly 80%, if you check their glucose parameters, 80% of them will have one abnormality of the other of glucose metabolism. Obesity is an important risk factor, as we know. High salt diet, frequent consumption of junk food, use of illicit drugs, psychiatric condition of the youth. A very important point that is missed out in this slide is frequent consumption of alcohol, which we all know that excess alcohol consumption is a very important risk factor for development of hypertension. I always recollect one of my friends who was my classmate in intermediate. I met him after many, many years. We, of course, went to different professions, and I met him after many, many years. And by the time he already developed a stroke, he was on 4 drugs for hypertension. And somehow, during my interrogation of this fellow, his wife told me, and he also accepted that he drinks too much. And all I said is that you give up your alcohol, you will become a normotensive, or at least it may come down so much that you may not require many drugs. Believe me, he really got impressed. He stopped alcohol, and now he just takes 1 drug for hypertension. He's a slightly obese person. He has no family history of hypertension. And now it is something like 20 years since he had that stroke, and he had absolutely no problem whatsoever after that particular consultation. So alcohol plays a very big role in the development of hypertension and perpetuation, and actually making it difficult to treat these patients. Systemic overdrive, sympathetic overdrive in development of hypertension is marked wrongly. Sympathetic overdrive in development of hypertension. Activation of sympathetic nervous system is a critical aspect of human hypertension. Studies have shown that muscle sympathetic nerve activity is increased in many types of hypertension in humans. Sympathetic activity is controlled by several cascades from peripheral inputs to central nervous system. We will elaborate on this in the slides down. It determines the central sympathetic outflow in the brainstem and hypothalamus. So sympathetic nervous system, in addition to renin-angiotensin system, plays a very important role in the development and sustenance of hypertension. The renin-angiotensin system is indirectly affected by sympathetic outflow from the brain, and due to activation of renin-angiotensin system, further worsening of hypertension occurs. So sympathetic outflow by its direct actions as well as by acting through the renin-angiotensin system worsens the hypertension. Heart rate and subsequent blood pressure in young adults. This is a particular study called the CARDIA study, and as evidenced in the coronary artery risk development in young adults, sympathetic overdrive is often accompanied by low parasympathetic tone, which further exacerbates the development of hypertension. Parasympathetic tone, if it is high, blood pressure actually comes down. That's how these devices have come, where people have implanted a low frequency stimulation of carotid baroreceptors, and actually these are one of the things that are tried as treatment of resistant hypertension. In fact, India also, a good number of patients have undergone this particular therapy, and of course it's not something that is accepted by FDA at this point of time, but it shows the importance of the parasympathetic tone. So high sympathetic tone and a low parasympathetic tone, they together go on to lead to hypertension. So this is a slide that shows several things. The brain's sympathetic overdrive in development of hypertension, leading to left ventricular hypertrophy, increased incidence of arrhythmias, increased oxygen consumption, heart rate increase, systolic heart failure, preserved ejection fraction. If systolic failure has not occurred, the diastolic dysfunction with resultant HFpEF. And in addition, the brain sympathetic output can lead to increased renin and the RAS activation, increased sodium retention, and decreased renal blood flow. And this can be interpreted by the kidneys as reduced plasma volume, and renal efferent nerves go on to the brain, and then they produce further worsening of this, leading to a vicious cycle. There can also be directly vasoconstriction and increased insulin resistance. Together, all of them lead to development and sustenance of hypertension. Activation of the RAS system has an adverse effect on the heart of hypertensive individuals. It increases the heart rate and eventually progresses to, it is not correct to say eventually, can lead to development of arrhythmias, particularly like atrial fibrillation. Sympathetic overdrive, sorry, go back. This is a good slide that shows a correlation between heart rate and risk of death. And when you see here on the right side, the heart rate in these individuals in this particular study is shown to be between 60 to 80. And here you can see all their parameters are low, whether it is coronary heart disease related mortality or overall CVD related mortality or all-cause mortality. When you go to the rate between 80 to 100, these figures go up. And when you go to the resting heart rate of more than 100, these figures go up much more. So it indicates that your resting heart rate actually is a very important determinant of long-term mortality. Everyone knows it. Whether this means that you should give drugs that will reduce the resting heart rate is debatable, but we know that This is one way of understanding that sympathetic drive is an important, it plays an important role in the causation of mortality and morbidity over years. One of the most striking effects of hypertension on the heart is left ventricular hypertrophy. We all know about it. I mentioned earlier also that, left ventricular hypertrophy's gold standard is echocardiography, but it can also be detected on electrocardiogram. And let me emphasize once again that if you see ECG changes of left ventricular hypertrophy, that patient's prognosis is far worse compared to a patient who has left ventricular hypertrophy, but the electrocardiogram does not show any changes. It has been suggested that around 36 to 41% of all hypertensives have left ventricular hypertrophy. Many patients who have white coat hypertension, one of the ways to detect it is the absence of end organ damage. One of the important things is left ventricular hypertrophy. It is not necessarily present in all patients of hypertension, but if it is present, then, and in the absence of any other cause for left ventricular hypertrophy, you have to understand that is probably having hypertension, and that hypertension is already leading to the left ventricular hypertrophy. You can see here that this diagram on this left side, that hemodynamic stress leads to hypertension. They're all kind of vicious circuit, renin, angiotensin, aldosterone system, and then that can lead to oxidative stress, inflammation, atherosclerosis, endothelial dysfunction, once again oxidative stress. So many of these pathophysiologic factors contribute to the morbidity and mortality of hypertensive patients. Okay, so blood pressure and cardiovascular health. Patients with left ventricular hypertrophy, a 2 to 4 times higher rate of cardiovascular events such as arrhythmias, AF-related strokes, etc., independent of other risk factors. So you have hypertrophy, you have hypertension and left ventricular hypertrophy. It straightaway indicates that the prognosis in the long term is worse than a person who has hypertension but no left ventricular hypertrophy. You can see here the cardiac effects are left ventricular wall thickness increase, left ventricular mass, and together you call it left ventricular hypertrophy. Hemodynamic changes may be higher mean pulse pressure, higher stroke volume index, higher total peripheral resistance index. Increased stroke volume and aortic stiffness contribute to isolated systolic hypertension in young adults. This is published way back in 2005 in Hypertension. So it is in young adults, one of the important contributing factors towards hypertension is the increased stroke volume. These patients have increased sympathetic drive, the rate may be increased, and the stroke volume is increased, and together the cardiac output is increased, and that may be an important contributing factor for the development of hypertension. Okay, this is a interesting diagram that shows on the bottom quartiles of pulse wave velocity as it increases, and on the left side quartiles of stroke volume. So when stroke volume is maximal and pulse wave velocity is maximal, the pulse pressure is highest. So isolated systolic hypertension in young adults involves elevation of stroke volume or aortic stiffness or both. Importance of treating hypertension in young adults. Well, it is important to treat hypertension in everyone. We agree today that octogenarians also will benefit by treating hypertension. But when it comes to young adults, obviously the importance is far greater because he is supposed to live much longer, correspondingly longer, and therefore the chances of developing adverse effects of long-standing hypertension are greater in these patients, in this group of patients, and therefore the greater importance of diagnosing and treating these patients. Hypertension in young adults can lead to serious health problems such as heart disease, stroke, and kidney disease. Young adults with hypertension are at increased risk for developing other health conditions such as obesity, high cholesterol, and diabetes. The first line says what are the effects of hypertension. The second line says the usual associations with hypertension, and they are kind of a vicious cycle once again, obesity. And it is common to find these comorbidities like diabetes, high cholesterol, and obesity in these patients. Hypertension is often a silent condition that can cause significant damage to organs. As exemplified by the first patient which I mentioned, it is a very classical example of hypertension being a silent killer. And in that particular patient, as I mentioned, he already has CKD, he already has retinopathy. And it's only a matter of time. If he does not control his hypertension, his condition get worse. So hypertension is often a silent condition, particularly in the younger people who really don't go for so often for checkups and therefore suffer more. Pharmacological factors in relation to beta blockers. We have to accept that beta blockers by and large are not considered first-line drugs for hypertension. We don't have evidence for that, and even guidelines do not mention that beta blockers are first-line drugs. But there are many situations in which, due to one or other comorbidity, are exemplified by this particular group about whom you are talking, the young hypertensives, beta blockers remain or become an important indication for this. Particularly, for example, if you have ischemic heart disease, you have angina, you have post-myocardial infarction patients, you have patients who have heart failure. All these groups, beta blockers automatically become important drugs for the control of hypertension. So that, let us say a patient of heart failure with or without hypertension is a candidate for beta blocker. But if he has hypertension also, you are even more happy actually to give beta blocker, because that helps this patient to a greater extent. And young hypertensives, because of so many factors as I mentioned, who have increased sympathetic drive, probably this is another group where beta blocker should be considered strongly. Beta blockers in treating hypertension. Beta blockers block the effects of catecholamines on the heart and blood vessels, thereby reducing the heart rate and force of contraction of the heart. As mentioned earlier, many of these patients, one of the important pathogenic factors is increased cardiac output. And there is already a resting heart rate increase and increased force of contraction. And beta blockers come in very well to reduce the heart rate and the force of contraction, and to an extent, a reduction of the cardiac output also, and thereby contributing to a reduction of the blood pressure. Effective in reducing hypertension in monotherapy or in combination therapy. Beta blockers reduce the risk of cardiovascular events by suppressing the release of renin and inhibiting the effects on CNS. Bisoprolol, when you talk specifically, it is a cardioselective beta blocker. It is one of the good agents to be called cardioselective beta blockers. In heart failure especially, out of the 3 drugs which are accepted for treatment of heart failure with beta blockers, apart from carvedilol and metoprolol, succinate, bisoprolol is another agent. The CBIS group of trials, which were published way back when, around the time when we just became cardiologists, bisoprolol was it was shown and proved clearly to be superior to placebo in terms of morbidity and mortality in relation to heart failure. Somehow in India, bisoprolol is, to my knowledge, not so commonly used. More often, doctors tend to use metoprolol, and in heart failure patients, carvedilol is particularly popular because of some of the important studies like US carvedilol study and so on. But bisoprolol has equally good and equally encouraging outcome results in relation to heart failure, in relation to cardiovascular events in post-myocardial infarction patients, and so on. And here we will look at the data in relation to hypertension. Bisoprolol blocks the beta-1 receptors, which lead to a reduction in CAMP and reduce the rate and force of contraction and reduce cardiac output, as I mentioned. Efficacy and tolerability of beta-1 selective beta blocker bisoprolol as a first-line antihypertensive in Indian patients diagnosed with essential hypertension, an open-label multicentric observational study. There are so many names, of which I immediately recollect the name of Dr. Somsundaram, my good friend. And this is published way back in 2012. Target BP was achieved in 96.44% of patients. These are smaller studies, and you cannot really say that you can quote it everywhere. But if you, in this particular study, the target BP was achieved in 96% of the patients. Bisoprolol can be used as one of the first-line antihypertensives in Indian patients. That is the inference from this particular study. This was published in BMJ Open in 2012. Efficacy and safety of bisoprolol compared to other selective beta blockers in the treatment of hypertension, a systematic review and meta-analysis of randomized parallel clinical trials. This has shown bisoprolol showed a significant reduction in heart rate, baroreflex sensitivity, and improved HDL cholesterol levels compared to other beta blockers, selective beta blockers. This is a little controversial, the data that is shown in this. Beta blockers usually increase the triglycerides and bring down the HDL. But of course, these are transient effects. They don't last beyond 3 months. But the well-known side effect on lipid profile is an increase in the triglycerides and a slight fall in HDL in these patients. Okay, effects of bisoprolol on heart rate variability in heart failure. We know that in heart failure patients, heart rate variability takes a back seat. There's a reduction in heart rate variability, which is not good. We want heart rate variability in our patients. In heart failure patients, this is reduced. By giving bisoprolol, you can actually improve the heart rate variability, which indirectly should lead to an improvement in this outcome of these patients. Another important thing is the effect on erectile dysfunction. We know that the best drug for erectile dysfunction among beta blockers is nebivolol because of its vasodilatory effect. However, in this particular trial, you can see here men with high blood pressure have 2 times higher risk of loss of libido and erectile dysfunction. There is an impaired penile blood flow and erectile dysfunction. These are common things to see in patients who have hypertension, and more so often in patients who have a combination of hypertension and diabetes, which is a very common situation which we face day in and out in our clinics. So the antihypertensives and sexual dysfunction, deterioration in sexual function, reduced quality of life, and non-compliance with therapy. Many patients who are taking beta blockers, they do come and say that there's a loss of the erectile dysfunction has become so common in our society due to early occurrence of diabetes and hypertension. And it's not uncommon at all for patients to complain about this particular adverse effect of the drugs, of the disease itself. And if the drugs add to it, then it can be worse. Antihypertensive and sexual dysfunction. Bisoprolol in this particular data has been shown to have very minimal effect on male sexual function. Carvedilol in this trial has been shown to have 13.5% increase of ED, propranolol 5.0 times, etinolol 3.0 times, and bisoprolol hardly any effect. This may be contested. Generally, it is mentioned that nebivolol is the best drug. If you have an indication, strong indication for a beta blocker in a patient who is likely to have erectile dysfunction, probably you should consider nebivolol. But the data from this particular trial shows that bisoprolol also is a good agent to consider in these patients. Importance of adherence to hypertensive treatment is 29% reduction in major adverse cardiovascular events, 33% reduction in CV mortality, 37% reduction in heart failure. This is a old and well-known thing compared to those days in 1940s and 50s when people said hypertension needs to be called essential hypertension because they said that you should not bring down hypertension. From that day, a lot of water has flown under the bridge, and we now accept that hypertension is an important contributor to adverse outcomes. And if you control hypertension, you will give them an improved life, cardiovascular events reduction, mortality reduction, chances of heart failure reduction, all are improved. And this is true even for older group of patients also. Non-pharmacological factors, lifestyle modifications for these patients is, some of them are mentioned because the young adults are likely to have some of these things. Smoking is more common in the young adults, taking alcohol, and not following a healthy eating pattern. So all of them you need to connect, educate your patient on the importance of quitting smoking, which will straightaway reduce his blood pressure by 2 to 4 millimeters of systolic pressure. Nearly similar effect by reducing the alcohol consumption. Follow a healthy eating pattern, about which we will talk again. Maintaining a healthy weight, and becoming physically active. These are all important, and I hope all of you who treat hypertensive patients don't merely prescribe drugs, but also educate the patient, spend some time about good lifestyle. The patient may or may not follow it totally, but at least it will have some impact on his lifestyle. Okay, we can skip this slide, which is not of much relevance for this talk. Now, look at this. This is a very important slide that shows the effect of various lifestyle changes that will lead to a certain degree of reduction of blood pressure. The first one is the weight loss. Maintain a normal body weight of body mass index between 18.5 to 24.9. And if you can bring down a 10 kg weight loss, it's not easy. Probably 10 kg weight loss is something you will see in patients who are, subject themselves to bariatric surgery. I keep telling my patients that if they are really obese, they should consider bariatric surgery. It will not only reduce their chances of hypertension in future, it also reduces their chances of diabetes. And in fact, you will see many patients of diabetes who are taking large doses of insulin. The moment they undergo bariatric surgery of any form, the requirement for the insulin comes down like 100% almost. They require very small doses. It is important they maintain that weight, but today bariatric surgery is something that has come in a big way in relation to weight loss. And if the patient can achieve a 10 kg weight loss, there can be a 5 to 20 millimeters fall of systolic blood pressure. Imagine 5 to 20 millimeters fall is a very big fall. If the patient follows DASH type of dietary, which means consume a diet rich in fruits and vegetables, low fat dairy products with a reduced content of saturated and total fat, once again 8 to 14 millimeters of blood pressure loss can be there, blood pressure fall can be there. Reduced salt intake, reduce the dietary sodium intake as much as possible, ideally to 65 millimoles a day, which is equivalent to roughly 1.5 grams of sodium or 3.8 grams per day of sodium chloride. We know there are certain primitive communities in this world who do not know what is salt, and they have a very, very low incidence of hypertension. And if our patients, Indian patients, salt intake, as you know, is significantly higher compared to many other countries, and if they can throw away at least partly the salt in their diet, it can once again lead to 2 to 8 millimeters fall of blood pressure. Physical activity. There is no need to emphasize the importance of regular physical activity, at least 30 minutes a day on most days of the week. Some of the societies say at least 150 minutes a week. And if they really do that, it not only brings down the blood pressure, it brings down the glucose intolerance, cut down the weight, or at least prevent further weight increase. And the benefits of regular physical activity, I can tell you, are endless. Moderation of alcohol intake. I would say, as doctors, if you say it is okay to take some bit of alcohol, the patient usually extends it and actually bulldozes his wife and says that no, it is okay. Doctor said some drink you can have, but it never stops with that. As a physician, I would tell my patients alcohol is absolutely bad for his health. There is some data that alcohol can increase the HDL that we all know, but how much, to what extent it will improve the patient's long-term outcome is really questionable. There are so many other aspects of excessive alcohol intake, like the effect on the liver, effect on the blood pressure, which are ignored by most of us. We only talk of that small, questionable evidence in favor of patients' health, that is an increase in the HDL, but forget about other things. And it is important, as physicians, we should not encourage intake of alcohol by any of our patients. If you, as I mentioned earlier, if patient can bring down his alcohol intake, there is a 2 to 4 millimeter fall. Another thing that should be mentioned is stopping smoking also will bring down the systolic blood pressure levels. So what is DASH diet? Dietary approaches to stop hypertension. I'm sure every one of you have heard this word, DASH diet, low in saturated and trans fats. Trans fats, the importance of which you all know, rich in potassium, calcium, and magnesium and fiber, low in sodium, and rich in protein. That is what is a DASH diet. Not easy to practice, but we should know about it. Now, this is a typical DASH diet where the vegetables and fruits form the bottom of the pyramid of DASH diet, and towards the top, and it's a pyramid indicating at the top are sweets and oils, and at the bottom are vegetables and fruits, meaning that it not in importance. The bottom is actually the wide part of the pyramid, and it shows the importance of eating lots of vegetables and fruits. It is not easy for every person in our society to follow this, but we should emphasize the importance of this. So, this algorithm for treatment of hypertension, you can see here in stage 1 hypertension, thiazide diuretics form the first choice in many times, and you may consider ACE inhibitors, ARBs, beta blockers, calcium channel blockers, etc., or a combination of it. In stage 2 hypertension, you already require straight away 2 drugs. Once you confirm that patient has stage 2 hypertension, it is not white coat hypertension. It is not one of those things which is one-time reading of hypertension. You confirmed the patient's hypertension by doing adequately home BP monitoring, multiple readings, and if required, ambulatory BP monitoring. And after all that, you have confirmed that he has hypertension, you can straight away go for 2 drugs. And in this algorithm, one can actually add young hypertensives who exhibit signs of increased sympathetic overflow, and particularly as evidenced by increased resting heart rate and other signs of sympathetic overflow. Probably in that group of patients, bisoprolol as a beta blocker is a very, very good agent. So, of course, if one of the other drugs has not given adequate follow blood pressure, beta blockers may always be considered to be add-on to the other drugs like ACE inhibitors and ARBs. All right. So summary is hypertension is a leading cause of death globally. Not only death, morbidities, which includes heart failure. Sympathetic overdrive accompanied by reduced parasympathetic tone accelerates the development of hypertension. Bisoprolol can be used as the first-line antihypertensive in Indian patients. Bisoprolol does not affect sexual function in young hypertensives. Rather, it affects minimally. Lifestyle and dietary modifications are important to manage hypertension over and above the drugs. Rather, probably drugs are over and above the lifestyle and dietary modifications. Conclusion, in young hypertensives, bisoprolol in combination with lifestyle modifications can improve hypertension control and reduce the risk of associated complications. Thank you very much.
A wonderful talk, very crisp and very clear. So now we'll go to the chat box. I'll ask questions later on. Nikki Ranjan, which way it is better than metoprolol? Bisoprolol, in which way is better than metoprolol?
Can I see these questions, sir? Where do we see these questions?
They have given in the side chat box.
Okay. All right. I'm not able to see it. Can somebody tell me? Anyway, let me take this question. It is not easy to say that this drug scores over metoprolol. If I, as a cardiologist, speak, the heart failure trials, the benefit of bisoprolol in CB's trial is almost as good or equal to that of metoprolol as seen in other big trials of heart failure trials. So, and you don't have a very clear head-to-head comparison in relation to metoprolol and bisoprolol. So it is not easy to say that one drug scores over the other. And one thing that is claimed is that bisoprolol may have lesser incidence of erectile dysfunction. So this is what I would say. For hypertension alone, most of these beta blockers, they come as slightly lower down compared to ARBs and ACE inhibitors and so on, as per the guidelines. For young hypertensives who exhibit evidence of sympathetic drive is increased, then these drugs are useful.
Yeah, I agree with Dr. Chandra. The metoprolol succinate has got the same equation like bisoprolol, whereas metoprolol tartrate has got lesser effect than the bisoprolol. So if you ask me which is better, bisoprolol is better than metoprolol tartrate. I cannot say the same thing as metoprolol succinate and the bisoprolol. And Sarachandra has given a very interesting point. If somebody, young fellow who has got erectile dysfunction, if you have to use cardiovascular drug, beta blocker, bisoprolol is better than metoprolol. So that way, I think it is better. Now the second question, Bhupinder Singh, what are activities lead to sympathetic overdrive?
Well, any activity which you do, whether you are, watching a movie or, a movie where there's a lot of action and anxiety and suspense, or you are doing physical activity, any of them, anything that stimulates your sympathetic system will produce increased sympathetic drive. It also indicates, it's also in relation to even sexual activity also. So most of your activities which produce, increased activity, whether physical or mental activity, will lead to a rise in the sympathetic activity. I just want to add one point. Most of regarding the earlier question, what Dr. Muruganathan said is very important. Most of the data in relation to metoprolol is in relation to metoprolol succinate. We almost don't use metoprolol tartrate after the earlier studies have come. Most of the data is in relation to metoprolol succinate, the long-acting metoprolol.
Yeah, and also there are some studies where if the patient has got COPD or asthma, the bisoprolol, nebivolol is better than metoprolol. There are some studies, of course, individual variation in the condition, the time, everything. So all the beta blockers have got its own benefits or side effects. For example, if it is migraine, propranolol is better. If there is atrial fibrillation or arrhythmia, propranolol is better because membrane stabilizing drug. So each beta blocker has got its own plus and minus. And the affinity of beta 1 selective was nebivolol. Nebivolol is 321, 1:321 compared to bisoprolol and metoprolol. So depends on the condition, depends on the age, depends on the comorbidity. So each one, we cannot say the same shoe fits everyone. One size fits all is not correct. Now coming to the next question.
I just want to say something. Can I say one point, sir?
Yeah, please.
The so-called, beta-1 selectivity is a very good point in relation to average doses. When the doses go very high, the selectivity is relatively lost. And any of these so-called beta-1 selective beta blockers, like, metoprolol or bisoprolol or any, these drugs, they lose their efficacy in relation to asthma worsening when the doses are higher. So that has to be kept in mind. It's good to say generally that you can use beta blockers in the presence of mild asthma if there is a compelling indication. For example, you have a patient of COAD, but he has heart failure due to left ventricular dysfunction, not right ventricular dysfunction, carpulmonale, which occurs in patients of COAD. If he has clear-cut heart failure due to left ventricular dysfunction and COAD, or for that matter, a patient who has got clear-cut indication, like in terms of recent myocardial infarction, in these patients, there is a compelling indication for beta blocker, even in the presence of COAD. But you have to remember this, that you start with a small dose and go up. And therefore, in case of an occasional patient whose COPD worsens, you may have to backtrack and remove the beta blocker. That's the one point I want to say.
Yeah. Now the Vijayaraghavan, in renal artery stenosis, patients does beta blocker decrease the renal blood flow or increase creatinine?
Well, we don't have really that kind of evidence. The one drug that actually worsens the renal function and renal blood flow are the ACE inhibitors or ARBs. In fact, people say that if you give a patient of hypertension ACE inhibitors and ARBs, and suddenly you see a drastic fall of pressure or a rise in the serum creatinine, you should suspect renal artery stenosis. With beta blockers, usually these things are not seen.
Yes. Now, Rukesh Gosai, how you justify role of beta blockers as primary antihypertensive when there is no compelling indication?
Well, if there is no compelling indication, then they're not the first-line drug. Why should I justify it? compelling indications, as I mentioned, are congestive heart failure, recent myocardial infarction, LV dysfunction due to any reason. Even if it is not recent myocardial infarction, if there is LV dysfunction that is persisting over years, these are all compelling indications for beta blockers. So there you can justify. If there is no compelling indication, you cannot justify the role of beta blockers as antihypertensive agents. Of course, with a certain bracket for these young adults who have high sympathetic flow and they have a resting heart rate increase and they have issues like excessive work, and you are concerned that they have increased sympathetic outflow, you can consider beta blockers in these patients. Very important thing
Also,
in that to see is, yeah, please go ahead, sir.
no, also in a
Please go ahead.
young women reproductive age when they are over sympathetic overdrive, and obviously we cannot put ACE and ARB because they are in the reproductive age. So that time also sometimes young ladies we give beta blockers. That's all. Manjunath is asking if we can give 2.5 milligram bisoprolol replacing metoprolol. Can we do that?
2.5 milligram bisoprolol along with metoprolol.
No, replacing metoprolol. Suppose metoprolol you are giving, can we replace with 2.5 milligram?
No, first of all, why should you replace a particular drug unless there is a reason? If you have a metoprolol 25 milligrams and patient is happy with that for whatever reason you are given metoprolol, there is no reason to shift him to whether it is 2.5 or 5 is an unimportant point, is a moot point. Why should you shift the patient from one beta blocker to another beta blocker? Unless you tell me what is the particular reason. Patient is not tolerating a particular beta blocker. That's a different matter.
Actually, this scenario comes, Sarachandra, in a government hospital or in a private hospital.
Okay.
There they don't get metoprolol sample and suddenly they get bisoprolol. They always equate, whether this 2.5 is equal. In government hospital, if there is no metoprolol, if they have a bisoprolol supply, this question comes.
Correct.
Abhay Singh Deora, my good friend from Rajasthan, is asking ideal beta blocker for patients with diabetes mellitus. Is it nebivolol or bisoprolol?
Bisoprolol, there is no evidence that diabetes control is worsened, particularly in relation to bisoprolol. Now, let me say a couple of points here. Any beta blocker can mask hypoglycemia that can occur in a patient. So, and as a cardiologist, I will say 80% of my patients are diabetics. I'm an interventional cardiologist, and almost most patients who come to us have diabetes. In that patient, because he has had a acute coronary syndrome, he had a proper STEMI, there is a compelling indication for beta blocker. Therefore, we really don't think twice about it. But in relation to your question, what exactly is the point, sir? His point is?
His point is, in diabetes mellitus, do you use nebivolol?
Yeah. So since diabetic patients with cardiac disease, there is a compelling indication. If that is not there in diabetic patients, my first choice for hypertension, suppose you have a diabetic patient who has no coronary artery disease documented, his LV echocardiogram is normal, there is no compelling indication for using a beta blocker. My choice in that drug is an ARB or an ACE inhibitor. And nowadays for resistant hypertension, a lot of people are using ARNI also. These are the drugs for diabetic patients without compelling indication for beta blockers because they don't interfere with diabetes metabolism. If anything, these drugs actually, ACE inhibitors, ARBs, protect their kidneys in the long run. With beta blockers, that kind of evidence is not there. So if there's no compelling indication, don't bother to use beta blocker. Because beta blockers, by their very nature, they tend to interfere with the manifestations of hypoglycemia. If hypoglycemia occurs, you have a problem there. The patient may not get all the classical symptoms of hypoglycemia, particularly increase in the heart rate, and the doctor to whom he goes with hypoglycemia may not find any, patient may not complain. This is very common in my patients because we go out of our way and check their A1C and blood sugars every time he walks into the clinic. And I find not often, patient says, I have no hypoglycemic symptoms at all, but his sugars are very, very low. And his A1C is very low. Sometimes it comes to as low as between 5.5 to 5.0. So these are patients who are having silent hypoglycemia. So you should be concerned about it. So beta blockers, use them in diabetics only if there is a compelling indication.
Correct. No, unless he has got vasospastic angina or any cardiac problem, we don't use beta blocker in diabetes. For the sake of hypoglycemic awareness may not be there, and people will land in problems. So then, Abhay Singh again, how to manage a case of young hypertensive who has associated problem of bronchial asthma as well?
Well, that's a very good question. If there is bronchial asthma also, I would say if you have to use a beta blocker, you use nebivolol. If you don't have to use a beta blocker, you don't have evidence of sympathetic overdrive. In those patients, you can use calcium channel blockers. You can use ARBs, any of those drugs which do not have much effect on bronchial asthma.
Sorry. Coming, but like questions. Can you, Sarath? Can you send us questions? I think suddenly your questions are okay. Vishnu Prasad Deka. Can we switch to new beta blocker from existing beta blockers?
Yeah, you can switch if there is an indication. I really do not see very great indications for such situations. I, as a cardiologist, go all out to produce a heart rate around 60 at rest. And if that is the aim, and you have given the patient, today, atenolol we don't use for a lot of data is there. That one article that came in JAMA, I'm sure Dr. Muruganathan has given many talks on this, that has put atenolol out of the market for practical purposes. Now our darlings have become metoprolol, succinate, and bisoprolol, of course, and many other drugs in India, particularly metoprolol is very popularly used. So if you are using these drugs and your aim of giving beta blocker therapy to reduce the heart rate, giving beta blocker is not just for the sake of it. You need to, if you really want to achieve beta blockade, the clinical sign of beta blockade is a reduction in the resting heart rate. And you want the rate to be as low as 60. If in my clinic I find a rate of 57, 60, I'm very happy with that given dose of beta blocker. Why should I change from one beta blocker to another beta blocker? If there is worsening of bronchospasm, patient is a chronic smoker, he did not complain of COAD-like symptoms, but after you started a beta blocker, his condition worsens, then probably that is a case for shifting to nebivolol. Otherwise, in most of the situations, you don't change the beta blockers. If the patient develops heart failure, you should use one of these three beta blockers: bisoprolol, metoprolol succinate, or carvedilol. So some of these areas, probably if the patient has migraine-like thing, as Dr. Muruganathan mentioned earlier, propranolol can be considered. Otherwise, normally, whatever beta blocker you are using, you should be satisfied with it. Step up its dose to the best possible dose to bring down the rate. Sometimes, despite using what is recommended heart rate, what is recommended dose, highest dose, you still don't achieve a bradycardia. In that case, sometimes ivabradine may be added to his symptoms, or if sometimes at a highest dose of beta blocker, a given beta blocker, patient is not able to tolerate, then you may have to step down on that dose and add ivabradine once again.
Yeah, I see. The situation comes sometimes. People are on atenolol for a long time. My mother was having atenolol for so long. Then we came to know atenolol is not that good drug. Then we have to shift atenolol to metoprolol. Now we use atenolol only in two conditions. One, if there is a liver failure, because atenolol is supposed to be good for liver, and also in HIV, the inter drugs acting is less with atenolol. So these two conditions only we use atenolol. Otherwise, we don't use atenolol. And if somebody has got atenolol for a long time, when they come to us, come to you or come to me, we say there is better that than atenolol, and we change. That's the occasion we sometimes change, because this is a common practice for us. That's why we do that. Okay, Abhay Singh Diora again.
Yeah, sir, I just want to make 2 points at this point of. They are good points which you raised. Atenolol, actually, I'm sure you agree with me, it's a very effective beta blocker. Unfortunate that particular data has come that it shows that it doesn't really cross the blood-brain barrier, and the patient's reduction of sudden cardiac death evidence may not be there, and so on and so forth. Otherwise, the atenolol is a very effective beta blocker. This is particularly true for me in patients who have rheumatic heart disease, mitral valve disease, and fast heart rate. All other beta blockers, they reduce the rate to a certain extent, but nothing like atenolol. For me, a rheumatic heart disease patient with mitral valve disease, a commonly seen patient is a young lady who has mitral stenosis in either with or without MR. These are patients for whom your idea is to bring down the heart rate, particularly if there is patient has got atrial fibrillation. The best drug is atenolol. When I mentioned this in one of the European Society of Cardiology meetings, the European cardiologists were all very depressed. They said, no, atenolol is outdated. We should use metoprolol. But the fact is, nothing controls the heart rate in a rheumatic heart disease patient as good as well as atenolol.
Yeah,
You may.
I think still we people use it, and I think we'll have the last question now. I will see the questionnaire. Mayank Prave. Between the equal dose of beta blocker. Yes, we already answered. What is the usual suitable dose of bisoprolol, and what is the maximum dose you can use?
Well, normal doses of bisoprolol we use are usually 5 milligrams to start with. If your target heart rate has not been achieved, you go to 10. Beyond 10, if you go, people have gone up to 20 also in some of the reports. The specificity of beta-1 selective blockade goes off. So usual working dose is 5 to 10 milligrams.
Okay, fine. And can you hear me?
Yes, I can hear you.
Yeah. Okay. Now, what are the main side effects of bisoprolol if you use continuously?
Well, being a cardioselective beta blocker, usually these patients do very well with this. I have so many patients in whom we regularly use bisoprolol. Nobody came and said any of these things. But the side effects are like, any of the beta blockers, like an occasional patient who has worsening of his lung condition, which is a smoker, history of bronchial asthma, COPD, etc. That is one occasional patient. Particularly, this is true if you use in very high doses. In patients like that, we tend to avoid very high doses, but that is one area. Erectile dysfunction, I have not seen any patient who came to me and said that he's having erectile dysfunction because of bisoprolol. So, usual mention is like this. Usual side effects like any other beta blocker. There's no specific beta blocker specific side effect in relation to bisoprolol. The other side effects that are mentioned are, masking of hypoglycemia, excessive fatigue, weakness, and so on and so forth. Of course, like, vivid dreams and lack of sleep. Usual side effects of beta blockers. To my knowledge, there's nothing very specific about long-term use of bisoprolol.
Yeah, it's sometimes individual variation. When you use drugs like antidepressants or nitrates or the baclofen or tamazolozine or levodopa and rifampicin, sometimes bisoprolol acts differently. So not everyone, but you must be careful when you use this drug, and particularly an individual where there is problem, then you'll have to think about interchanging of drugs. Otherwise, bisoprolol is a very good drug, safe drug, no side effects. Compared to other drugs, it has the same beta blocker side effects, not much.
Even in renal insufficiency patients, unless the renal insufficiency is severe, like EGF or less than 40, bisoprolol can be used very happily. And similarly, unless it is severe liver failure, bisoprolol can be used without any impunity. It is excreted both by the kidneys and the liver, and therefore, unless the patient has got liver and renal failure both, in majority of the cases, unless the insufficiency of the liver or kidney is severe, bisoprolol can be used without any hesitation.
Yeah, actually, bisoprolol starts acting in 2 to 3 hours, but the full effect of the bisoprolol may sometimes take to 2 to 6 weeks also. So sometimes you'll have to wait. Suppose you give the drug and you say there is no effect, you have to wait at least 2 weeks before you do that. So I think there are no more questions now. We will have to conclude. I think final message, Sarachandra, for the audience, some drive home message, not only for beta blockers, generally about hypertension. Your final message to the audience.
Okay, once Dr. Muruganathan asked me to give a talk on hypertension in children, in pediatric age group. At that point, as I was going through the different publications, I find childhood hypertension has become a big thing in India, all over the world probably, because there is an increase in childhood obesity in the United States also. But in India, this is a very big problem. When I used to go to drop my daughter in the Jubilee Hills Public School, I used to find a whole lot of young kids with obesity. So they were all less than class 10. So important thing is start checking their blood pressure and blood sugar right from the school age. That's a very important thing. Regular checking of blood pressure as the person grows older is very important, and it is very well exemplified by the patient about whom I mentioned. He never underwent blood pressure checking. Today, it is impossible to believe that such patients exist, but they do exist. So, preventive checkups are the key to prevention of long-term cardiovascular events, or for that matter, any adverse effects of hypertension. So, frequent checking of blood pressure starting from a very young age. This can never be overemphasized. The World Hypertension Day, one of the messages is start checking your blood pressure, treat it effectively, and live longer. Probably that applies very well to hypertension. What is your take on this, sir? I mean,
Yeah,
you've seen
no,
hypertension day in and out.
yeah,
You
yeah.
know so much about
Actually,
it.
yeah, actually, in Hypertension Day, we must create awareness first. Many people they don't check the blood pressure. That is why I said opportunity screening. Even if they come for a headache or some accident, some little finger pain, we have to check the blood pressure. I go one step further. I check the blood pressure for the attenders also, so that this opportunity screening gives you an idea who are the hypertensive. Because in India, the awareness is less and the control rate is less than 12%. So how do we control? Only by awareness, and then start treating the patient. And one thing which I, in my experience, have found out is promoting home blood pressure monitoring, because now people now learn to use home blood pressure monitoring. That gives the empowerment for that patient to know that he is hypertensive, whether drug is acting or not acting. So promote home blood pressure monitoring. And my passion is you should have hypertension specialist who focus on hypertension. Hypertension is much more prevalent. Mortality, morbidity is more than 3 times more than diabetes. But nook and corner, we get diabetologists, but we don't have hypertensionologists or hypertension specialists. So we want the speaker, I mean, the learned delegates to focus on hypertension, maintain a hypertension registry, promote home blood pressure monitoring, and advise them as early as possible, aggressively treat them. Don't have clinician inertia, and then lack of adherence is another reason why the control is not there. Now the drugs are very cheap, and lifelong you have to give the drug. So counsel them the day one and tell them to adapt. I mean, observe lifestyle modification, simple style. What Sarchandra said, dash diet, less salt, less fats. All these things will go in a long way. More than that, your lifestyle modification, like you must be calm and not under tension. Check the pressure periodically, and go to the doctor regularly. Adjust the dose, and then have a long life. Live longer. Accurate measurement and live longer. Control the blood pressure. This is the message of the World Hypertension. This is applicable for all the days, not only World Hypertension Day. Every time, you'll have to do this. So I thank Sarachandra for the excellent discussion and then excellent exposition of the topic. And beta blockers are the good drugs in hypertension, especially in Indian setup. We have to use. Of course, European guidelines says one of the drugs is beta blocker, but whereas American guidelines, in the first 4 line drugs, beta blocker is not there. But whereas Indian hypertension guidelines, we also say beta blocker, because as Sarachandra said, Indians are more sympathetic overdrive, and so we'll have to use beta blocker. So thank you very much, Chris and Alice Murthy, for making us to
Thank you,
discuss
sir.
this important subject. And I thank Sarachandra for the excellent talk. I think you should keep this in the website so that people who missed it can listen to Sarachandra leisurely and
Yes.
learn a lot of new points. Yeah, over to you for
Right.
conclusion.
Yeah. Thank you, sir. In fact, sir, taking cue from what you just said, The recording of this webinar will be available on the Microlabs website. So it will be archived there. So doctors who have missed it can always go and see, sir. And it's also on YouTube. So they can also go there and see. So, sir, from Microlabs, I thank both the doctors for an excellent. I mean, this webinar has gone on for more than 1 hour, sir. To be precise, it has been an excellent, lucid presentation by Dr. Sharat Chandra. Thank you very much, sir. And Dr. Muruganathan, thank you so much for moderating it so well. In fact, a lot of points have come up and a lot of questions were answered in detail. So I'm sure there had been a lot of take-home points for the audience as well. And I thank all the doctors who had participated, and would like to tell them that this Beating Heart webinar series will happen every month, and we will come back to you with a new topic next month. So on behalf
So
of
what you have
Microlabs,
to, Hari, what
yes,
you
sir.
have to do, if you are
Yes.
doing a series of meeting, you should announce what are the titles you are going to discuss. So that will be like a master class. What Sarachandra and myself are doing, we had 31 webinars and 31 days that we have given the topics. And
Okay.
Sarachandra discussed about hypertension in children. So like that, next time hypertension in elderly person. Like
Sure.
that, if you have the series of talk, people will
Okay.
be happy to join and then learn.
Dr.
Absolutely, sir.
Muruganathan's, website, the Hold Academy, so much of, academic discussions take place. It's really mind-boggling to listen to him and his colleagues. One of them, of course, is Dr. Rajshekhar from Kumbakonam, and
Okay.
another doctor is Palaniyappan from, where is he from, sir? I think Trichy. Uh,
Yeah, he's Chennappan.
Chenniyappan.
Chennappan. Dr. Chennappan.
Yes, correct.
Dr.
Correct.
Chennai,
And
yes.
they're outstanding speakers, and sir's presence there. I would tell all these young fellows who are listening to this particular discussion today, they should just go to Hold Medical Academy. And in fact, I registered more than one fellow for that, so that they can also not only read about what is written there, also listen to many of these webinars that go on. Thank you very much, sir, for chairing this session. And
Yeah,
my sincere thanks to Murthy and all other colleagues from Microlabs at Hyderabad and at your headquarters. Thank you so
yeah.
much.
Thank you, sir.
In fact,
Thank you.
Sarachandra, it is
Thank
because
you.
of you I agreed to
Yes.
be a moderator because tomorrow I am going out of country, so I have to
Oh,
do a lot of
Okay.
arrangements. But because Sarachandra is giving, it's my pleasure to be with him, and we always together do a lot of good things. And he's a great academician. Hats off to him. Thank you very much,
Thank you, sir.
Micro. Continue your good work. Next time you can
thank you, sir.
add Kahoot. Kahoot also. There's a multiple choice
Yes.
questions which you can add also in Kahoot. Whenever we do, we include Kahoot also. It's a multiple choice question. I will show you next time. We can
Right,
get the
sir.
questions from the speaker and can put 10 questions. We make the audience also participate. So that'll be
Yeah.
interesting for them also to involve them. It's called
Sure,
Kahoot.
sir.
Okay,
Kahoot. Yes,
fine.
yes.
Thank you.
We will
Thank
do
you.
that. Thank you.
Yeah.
Thank you,
Thank
sir.
you, all
Good night.
doctors. Thank you very much.
Thank you, sir.
Thank you. Bye-bye.
Thank you. Namaste.